TopMedTalk.
Well, hello and welcome to Anesthesiology 2024. We are TopMedTalk here in the exhibit hall for the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell. I'm your host, and I'm joined by a couch full here at TopMedTalk. But first, I want to introduce my co-host, Professor Mike Grocott. Mike, thanks so much for coming back.
Desiree, great to be here. We have, as you say, a full house.
And
in the house, we have our founding editor-in-chief.
Oh, well,
There you go.
thank you for that. I was just tired. You let me sit down. It's good. Great.
How are you, Monty?
Great. It's good. It's very good. It's good to be here. Feels great to be back.
Yeah, normal on the couch. I know it's a little sad, though. You haven't been able to join us as much.
Well, I think we've overtold people. I joined Edwards Life Sciences just over a year ago, and very recently, Edwards Life Sciences Critical Care was acquired by Becton Dickinson, so I now work for BD, Advanced Patient Monitoring.
There you go.
It's good to be here.
All
Still
right.
an emeritus prof at UCL, though.
Yes, and still here with us on TopMedTalk during Anesthesiology 2024. Well, before we introduce our wonderful guests, we just wanted to give a huge shout out to the ASA for supporting us to be here in the exhibit hall with this beautiful booth stage. We're right next to center stage. I'm here in the mix of it all. So thank you very much. And also thank you to our sponsors, Medtronic, GE Healthcare, and Edwards Life Sciences. That is what keeps TopMedTalk free and open access to the entire world. So thank you so much. And thank you to our listeners for staying with us. This is, I think, our 5th year here at Anesthesiology, or 6th year here at Anesthesiology. And so thank you so much for joining us. So without further ado, we want to introduce our guests. One, a repeat customer, I will say. We have Ben Gibbison from the UK. Ben, thanks so much for joining us.
Hi, thanks. Nice to be here.
Yeah, we talked last year about the GAP study, I believe, and we're going to maybe touch on that a little bit more today.
Yeah, hopefully.
Yeah,
That'd be
that's good. All right. And then we have Dr. Joshi from UT Southwestern. Dr. Joshi, I've been wanting to have you on TopMedTalk for a very long time, especially after the MPO guidelines came out last year. That was a topic that you're first author, I think, on those guidelines.
Yes.
Yeah, thank you so much for joining us.
Thank you, Desiree, for inviting me.
Yeah, well, for our listeners, tell us a little bit more about yourself.
I'm a professor of anesthesiology and pain management at UT Southwestern in Dallas.
Mm-hmm.
I've been there for about 30-odd years.
Oh, okay.
Been there a long time.
And some of your research interests?
Most of my research is in pain management, ambulatory anesthesia, and enhanced recovery.
Yes, enhanced recovery. I know we see you a lot in that space. Well, very good. Well, we want to kind of dive right in and talk about something that is, not specific, but part of enhanced recovery guidelines. We talk a lot about that on TopMedTalk. But also very hot in the press right now is fasting guidelines for anesthetic patients or patients going under anesthesia. So those guidelines came out last year. Can you walk us through just high level what the guidelines are saying now?
So these guidelines were an update of the previous ISA fasting guidelines. And we specifically in this update looked at fasting for clear liquids, carbohydrates, and chewing gum. And we did all the typical systematic reviews, meta-analysis, and confirmed that the ASA recommendation of 2 hours for clear liquids, as well as for clear carbohydrate solutions, is still appropriate and should be followed. In fact, this guideline, we emphasize that we need to hydrate the patient significantly during the fasting period, fasting for solids. And subsequently, after the paper was published and we finished our analysis, there were 3 other studies that in fact went a step ahead and said 2 hours for clear liquid may be a little bit too long. Maybe we should have the so-called 640 rule.
Yeah.
As you know, the ASA recommendation is 642 rule. That is 6 hours for a meal,
light meal,
and 4 hours for milk and 2 hours for clear liquids. That's the current ASA recommendation.
Yeah.
But the subsequent papers actually emphasize that you can have a patient drink water up to a glass or so until the patient's ready to go to the OR, and still is safe. One of the largest studies basically looked at aspiration and found no increase in aspiration, but increased patient satisfaction.
Yeah.
Even our ASA update showed that patients who were allowed to have that clear liquid until 2 hours had significant satisfaction, less thirst, less hunger.
Yeah, anxiety and hunger and some things like that have all been tied to that, hasn't it?
Tied to it.
Yeah. So interesting. We've talked a little bit about this on TopMedTalk, about the change in MPO guidelines and some of the work actually that's come out of the UK, right? There's some new initiatives and data to show that there isn't the assumed risk of aspiration if you let people drink water, right, up until surgery, correct?
So I guess we've had changes in practice, and maybe the discussion in a moment will come on to how we can interrogate that from a research perspective.
Yeah.
The notion of sip till send.
That's what it is.
So maybe a 200 ml glass of water or a clear liquid, black tea, black coffee, sipped right until the moment when the patient goes to theatre is becoming relatively widespread in the UK. We're not quite sure how much, and the Centre for Palliative Care is at the moment initiating a survey to understand that better.
Yeah.
But I know the discussions around that have centred on how will we know, that the adverse events we're talking about are so rare.
Yeah.
Will we really actually know whether this is safe or less safe, and how do you balance the sort of competing harm of patients who are dehydrated sometimes for hours?
For sure. Monty?
Like one of the conversations we had when we tried to get the widespread adoption of enhanced recovery principles in the UK is that when I was a young intensivist, admitting somebody from recovery who'd aspirated was relatively common. Now, it might have been the type of anaesthetics were given, the way the airways were protected, but in the wake of changing the fasting rules, anecdotally, it just went away. We sort of almost admitted nobody for a period of time. Now, we'll come back to the fact that might have changed relatively recently, but there's a long window where it was unusual to admit anyone.
Yeah, in my experience, it's always limited, but I don't think that has changed relatively recently.
I used to work on busy intensive care units.
Absolutely.
So we'd have the community would discuss it.
Yeah.
But now we've got the thing which you're going to get to, which saddened me about this whole journey relatively recently, is we now have some new drugs that delay emptying of the stomach.
Yeah.
And now we're at risk of everyone saying, I told you so, and the whole thing reversing itself.
Yeah.
I just want to add to this. Though we recommend, and the recommendation from several societies has been the 642 rule, patients are still fasting for a prolonged period of time.
Yeah.
We advise our patients to fast after midnight, but most patients will have their dinner maybe 6:30, and then they will not eat anything or drink anything.
Yeah.
So the first step, I think, is having guidelines has not really changed practice. We need to really give very specific advice to our patients. And that's what we have done in our enhanced protocols. What we ask our patients to do is basically have at least a glass of water or two before going to bed.
Mm-hmm.
And then before they come to the hospital, because all our elective surgical procedures, patients come on the day of the procedure, drink a glass or two of water. And if you want, you can have Gatorade too. So that specific advice is lacking. We need to do that.
Two perspectives. One, what do they do in Bristol? So you sit till send widely?
Yeah, it's very widespread in both the two large hospitals in Bristol. In fact, I was walking up the stairs the other day, and there's big posters to just tell everyone in the stairs that it is normal to sip send for staff, patients, everyone.
So to enable the patients to help drive that?
Yeah, absolutely. So do not worry about it. You will be asked to drink water until the time of surgery. Clearly there's exceptions to that, emergency surgery, guts, things like that, people on opiates and stuff, but other than that, it is.
And your perspective as a trialist on whether this is an answerable question?
No, well, we were talking about this beforehand. These rare events are really difficult to get data for or to actually do as a trial on. And even trying to do it using routinely collected data, I'm not sure how well it's recorded. Aspirations recorded, and actually clinically significant aspiration that puts someone on the ITU. Where's that recorded? How well is it recorded? It's just not there. And how did people actually follow the guidance? So I think this stuff is really challenging to produce guidance for, evidence-based guidance. I was sort of interested to know how you actually produced that guidance.
So as far as aspiration is concerned, it's very impossible. Impossible. So example, you may have an incidence of regurgitation, but has that regurgitation resulted in aspiration?
Yeah.
Even if you have aspiration, is it significant enough for the patient to have a prolonged stay in the recovery room, forget the hospital, or a need to ICU admission? Then, even if somebody's sent to the ICU for a day overnight, is it necessary? And so there are so many questions, and therefore to do a proper study to find clinical relevance of aspiration, we'll need millions of patients, and therefore it's unrealistic. But we still need to proceed with this to theater or 640 rule for patient satisfaction. For patient needs to feel good, and we know that that will improve outcome.
So while I have you guys here who, physiology background, physicians, if you talk about the physiology or pathophysiology of this, a lot of people are worried about aspiration. If you have MPO and they don't have anything in their stomach, it's full of stomach acid. I mean, how many times have you put an NG tube in and you get tons of clear or tons of acid, and they've been fasting? So is it actually better if we put water in the stomach and increase the pH? Does that change, aspiration and the severity of that?
Yes, obviously. In fact, there's so much good data. When we drink water, even in patients who have diabetes or obesity, 1 glass of water's half-life is only 10 minutes.
So both gastric and
yes, and in that acid's also basically moved on. Not only the pH is increased, but the acid is basically moved to the duodenum.
Yeah.
So there's good data to, at least theoretically speaking, given water is not a problem, and it will basically be removed from the stomach. So imagine now, patient wants something to drink just before they're going to the OR, and somebody's concerned, but by the time they go to the OR, we put the monitors on, we do all the setup timeout, you got the 10 minutes.
Yeah.
So I think we shouldn't be really worried, but the problem is changing behavior.
Yeah, it's so bad.
And Dr. Joshi, the challenge that Monty highlighted around the new anti-diabetic obesity medicines, how did you deal with that in the guidelines?
In the guidelines, we didn't address that. The reason is it was not perceived to be a problem then.
Yeah.
You and these these guidelines take a year or two to develop, and the problem of GLPs came to light last year around July or August, around same time when the guidelines were ready to be published.
You can't really make change that way.
You cannot make change. Nevertheless, because I was the chair of the task force of the guidelines committee, the ASA hierarchy came to me and said, we got to deal with this problem of GLP agonists because our members are sending us emails saying patients are aspirating. So it was and is still a real problem. At that time, because we had limited evidence and we had to come up with a guidance quickly, we emphasized, educate our members and anesthesia practitioners that regurgitation and aspiration with GLP-1s is critical. So we came up with guidance with minimal evidence. And one of the things was, hold on your GLP-1s for a week, which now we are going to change.
Yeah.
So in fact, we have a multi-society guidance which is now agreed upon. It starts with ASA, the GI societies, surgical societies, SAGES, and many others. So we have about 6 or 7 societies, and we have come to a consensus. It's going to be published in multiple journals on October 30th. And the guidance here would say that identify the patients who are at high risk of regurgitation, those who are high risk of gastric retention, and these are the patients who are basically in the escalation phase of the GLP, patients with significant nausea, vomiting, and those are the patients where you have to be extra cautious, but we do not recommend holding the drug.
So no one gets help. It doesn't get help for anyone.
I wouldn't say no,
high risk,
but very high risk.
Yeah. Okay.
They will be held because again, holding just for a week is not adequate.
I'm not sure if we do or don't have the science yet, but on a balance of probability, sipping to send is unlikely to make the circumstances worse.
No.
Just from first principles.
Absolutely.
So it's...
So that's another thing I cannot emphasize enough. People are misunderstanding this retention, gastric retention with GLP-1 agonist, which is more for solids than liquids. In fact, taking water is still going to be moved into the duodenum within that 10 to 15 minutes. So we have to emphasize it's the solid food. So the other guidance which we have provided in this new update is that maybe in the very high risk patients, you have the so-called liquid diet for 24 hours.
Yeah.
The same as what we have for colonoscopy. So, but give them liquid. Don't hesitate to give them water at least, even in that patient population.
Yeah. Ben, does any of this sound familiar from a UK perspective?
Yeah. What in terms?
GLP-1, are you guys
we
prevalent?
well, this is why I was sort of interested, because we don't see a lot of it. People, or I don't see a lot of it. I don't know about you, Mike. It's not as prevalent as the US, I think, because I think you can get it on private prescription, but I've yet to see anybody on it.
I think so many of our diabetic patients are truly on it for diabetes, and I didn't know if from cardiac perspective.
We don't see that many people on it from a diabetic perspective.
I think we're just about to. I mean, there's government.
It may well come our way soon.
And there's
at the moment it's not.
I think so too, because not only the American Diabetic Association has recommended GLP-1s as a first line, but I understand even the European Diabetic Associations are now recommending these drugs as first line. But the biggest jump in my mind is the obesity.
Yeah, absolutely.
And the problem we find is patients are on these drugs and they don't tell us.
They are afraid to tell us they're on it because they're getting it from a telehealth.
Yes, or online from somewhere. And we had a patient recently, lost weight, but obviously we see them for the first time. She came for simple shoulder arthroscopy, outpatient procedure, didn't tell us. And we didn't ask. So one of the things I want to emphasize is we need to now ask the patient, are you on this drug, as a proactive approach? Because we didn't ask, she didn't tell, everything went fine. And at the end of the procedure, after she was extubated, she regurgitated and aspirated. So that's the second message which I want to give, is not just induction, but also at extubation, we got to be cautious in this high-risk population. And she was getting the drug online from somewhere, and she was still in that escalation phase.
Yeah, interesting.
Look, some people have suggested recently that we should all learn to do simple gastric ultrasound. Is that a bridge too far?
No, in fact, that's the next thing I was going to come to. So the way we have done this recommendation, and I'm going to be speaking on this at my refresher course here, is what to do day before surgery and then what to do on day of surgery. So unless the patient, is fine, has elective surgery because the patient is not in the escalation phase and has no GI issues, comes on the day of surgery, now has GI problems. Well, that's the patient where ultrasound would be great. Or somebody who's really not feeling good, bloating. So I think all of us need to learn appropriate way.
There's a proficiency that right.
Then give me a sense. Sorry, I'll let you in a second, Ben. Give me a sense. How long would it take to teach even me?
Oh, very easy.
Okay.
So the learning curve is very kind of steep. 6 or 7 attempts, or 6 and 7 in my mind. Doing it right, somebody who teaches you right, you will be good at it.
Yeah.
No, well, that's what I was going to ask, actually, because I don't know what it's like where you work, but I'm not sure many of my colleagues are fully trained in gastric ultrasound, and I just wondered how long it would take to sort of train up the 130, 150 anaesthetists in our hospital
Very
to do
quickly.
that.
Yeah.
It would be quick.
And the problem occurs when patients are obese, like we have many. I don't know about UK. But start learning on a relatively, maybe on Monty, relatively thin person, and then move on.
And then the thin person.
All right, so I want to switch gears because there are a couple more topics, just kind of rapid fire here that we want to ask about. First, while we're still on the NPO and Ciptocin and all the things, we have an IV fluid shortage. Don't know if you've heard about that, but we have one here in the U.S. due to Hurricane Helene that came through and destroyed some of the transportation routes in North Carolina. What are the recommendations, and what is the ASA giving some guidance around that?
So I don't have any official information from the ASA.
Yeah.
Obviously, the ASA has some guidance, but I'm not right person to talk about it. I can tell you what we are doing at our place and what ideally could be done. So first, obviously, that brings up the loop of emphasizing pre-op hydration.
Yeah, for sure.
If your patients are hydrated very well, the need for intra fluids is going to be significantly less. And the way I look at this whole problem is that, at least in the U.S., 70% of our procedures are done on outpatient basis. We have 5,500 ambulatory surgery centers. About 80% of those procedures are 2 hours or less. So hydrate them well, put in a IV, don't start the infusion. Have small amounts of these syringes, which we have 10 cc flush syringes, which get flush the drugs. For 2-hour procedure, you don't need fluids.
Yeah.
And that takes care of about 50% of our patient surgical population.
Yeah. So one of the things I wanted to emphasize, though, because I've been hearing this a lot from institutions and clinicians across the country in regards to this, is a lot of people are saying, okay, fluid restrict. If you have hypotension, go ahead and give neosynephrine and keep that pressure up.
No.
And as anyone that listens to TopMedTalk knows, that some of the work that I'm working on to make sure we're treating hypotension the right way. So in that particular instance, Dr. Joshi, what would you tell your providers?
So again, we've got to use logic.
Yeah.
And these are trying times. And so we got to use logic. In my mind, yes, after induction, if there's hypotension, you want to correct it. We know what the causes are inducing that. So be cautious with induction. At least in the U.S., a lot of people get maybe 100 mics, 150 mics of fentanyl at induction, which is not necessary.
Mm-hmm.
So caution with the induction. And if there's post-induction hypotension, post-intubation hypotension, then maybe phenylephrine is fine. But using that overall without any thought process is not appropriate.
Yeah. Okay, and lastly, you mentioned enhanced recovery as a specialty something that you're interested in, and we talk about NPO status, and that's where a lot of us have seen that change, and if we see that in practice, we see that. A big change in enhanced recovery recently has been the omission of utilizing gabapentin, especially in multimodal pain management schemes. So you're going to be talking about that today.
I talked about
yesterday. Yes. That's right, yeah. Yeah.
So almost a decade ago, gabapentin came into vogue for management of pain to decrease opioids. And this opioid crisis, I'm sure you were there at the opening session, opioid crisis has gone overboard now. And so one of the attempts to decrease peri-op, post-op opioids is the use of gabapentinoids, and whether gabapentin or pregabalin. At that time, the evidence was there, but very limited, and still we followed that because we wanted to decrease opioids. Subsequently, what I presented was that the evidence of efficacy is questionable. And yes, the previous studies did show opioid reduction, but they were not clinically significant amounts. So having statistical significance is not adequate. So now I'm hoping people have stopped using gabapentinoids as their so-called multimodal anesthesia technique because of the lack of efficacy and potential side effects. Nevertheless, what we do, and I would suggest, is if the patients are already on these drugs, they need to continue.
Yeah.
But don't start them before surgery.
Yeah. So I would advise everybody to go back and listen to our interview with Ben last year about the GAP study. But Ben, high level, talk us through, because some of the research that you did has now informed this.
So we did a trial last year, which Mike was involved in, a randomized controlled trial of gabapentin in major surgery alongside multimodal pain relief, a pragmatic clinical trial, 7 NHS centres in the UK. Just under 1,500 people. We had to bump back a few. We dropped the power from 90 to 80% after COVID, just to struggles recruiting people. And the trial was powered for length of stay, so clinical effectiveness as well as cost effectiveness. And it showed no difference in length of stay after surgery. So major surgery, had to stay in hospital 2 days, or expected length of stay 2 days. So major, thoracic, cardiac, abdominal surgery, no difference. Small changes, as you say. We had small, non-significant changes in opiates and small, non-clinically significant changes in pain, 1 point on a 10-point scale. But it made absolutely no difference in the number of side effects, absolutely no difference to the speed you got out of hospital. So certainly the last recommendation of the paper that's currently under consideration is that we don't think it should be used as a sort of routine multimodal analgesic.
And Ben, for your other multimodal, just quickly what people got routinely?
Yeah.
The other components?
We allowed them to give whatever they gave normally. So it excluded everything else. So they all got paracetamol. Most of them had paracetamol, and most of them had some sort of opiate.
And an NSAID?
Not necessarily. Some of them had NSAID, some of them did. It was major surgery, so pretty much the cardiac ones didn't, and quite a lot of the thoracic and the abdominal ones didn't get it because they were older. So, it was mainly opiate related.
And block at will?
Yeah, so we didn't allow sort of profound neuraxial blocks like spinals and epidurals, but you could block anything else you wanted to.
Which everybody does.
Yeah,
you
yeah.
put a logo in.
Do your tap block.
Yeah. What about ketamine?
So people did use ketamine within it. A proportion of people use ketamine, and I'm moving away from ketamine. Not that I ever used it particularly. We're just patients don't like it when you get when they come back. They really don't like it.
Especially with us not using Versed that much anymore and getting rid of that, it really sucks, Joshi.
So I just want to add to the ketamine problem.
No, well, we have a big problem in Bristol.
People are using ketamine like water, and at least here in the U.S., even for outpatients, they're giving about 25 to 50 milligrams of ketamine, forgetting that even that amount can cause hallucinations, sleep disturbances. We know sleep is very important. In fact, Andrew Moore had an excellent article in BJA, and the title of that article was False, Fabricated, and Futile Studies. Flawed, Fabricated, and Futile Studies. Fabulous article where he looked at ketamine, Cochrane analysis of ketamine, and completely ripped that whole Cochrane analysis up. Showing that the data is significantly lacking, and what's out there, though there are many studies showing benefit, they were not done appropriately because appropriate, we call as basic analgesics like paracetamol and NSAIDs and regional anesthesia and dexamethasone was not used. So that's why we've got to be cautious with ketamine.
Well, this is a fantastic conversation and a true round table, getting to some of our roots here on TopMedTalk. So thank you guys so much for joining us and sitting down. And thank you for listening to TopMedTalk. You can always find us on social media. We're on X, LinkedIn, Facebook, YouTube. If you're there, give us a thumbs up. We always love that. Thanks so much for listening. And again, thanks to the ASA for this fabulous booth and enabling these wonderful conversations. Cheers, everybody.
Thank you.
Cheers.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.